We will now open the hearing for LB 895. Senator Walls.
Thank you. Good afternoon, Chairman Archer, members of the Health and Human Services Committee. My name is Lynn Walls, LYNNEWALZ, and I proudly represent District 15. And I'm here to present LB 895. LB 895 requires the MCO's prior authorization process be more transparent, more consistent, and more timely. Currently, my understanding is that Medicaid patients seeking chiropractic, physical therapy, occupational therapy, or speech language pathology services are being denied authorization, and it's unclear to providers as to why they would be denied this coverage. So they're just not giving any reasons why, or it's taking a long time to get a reason why. I'm also hearing that it's taking up to 2 weeks for patients to receive a response from managed care organizations to let them know if they will be denied or if the claim will be modified, In addition, I have concern for patients that have been involved in life-altering accidents not receiving treatment based solely on the wait for authorization from managed care organizations. I should be clear that there are some MCOs that are already following this procedure. But this bill would make sure that current and future contracted managed care organizations are all on the same page of transparency and timeliness. In anticipation of the new RFP, we're just trying to ensure that whatever managed care organization the state contracts with now and in the future are all going to be held to the same standards and are meeting the needs, more importantly, meeting the needs of the patients. If we start at Section 2 of the bill, we are asking that managed care organizations use evidence-based clinical guidelines, and we are also asking organizations to make available their guidelines on their website so all providers can comply. Moving to subsection 2, we are asking that people who are approving, modifying, or denying claims be healthcare professionals for the same discipline. We want to make sure that the people making these decisions understand the necessity for the type of care the patient is seeking. In subsection 3, we address the process for a patient seeking care for an accident. And to expedite that process, we are asking that there is not a requirement for prior authorization for up to 12 initial treatment sessions. It is important that a patient seeking care from a chiropractor, physical therapist, occupational therapist, or speech language pathologist due to a life-altering accident receives immediate care. In subsection 4, we are asking for timely payment by managed care organizations not to exceed 15 business days. This is outlined in the rules that managed care organizations should already be following. Subsection 6 requires a 48-hour response by managed care organizations to deny or modify a prior authorization request. What I've heard from providers is that it is imperative to make the next appointment, and I completely agree with this because once you leave the office, it's hard to get your appointment, but to make the next appointment while the patient is in the office. That means that it's all the more important to make sure that they are ready for authorization as soon as possible. Additionally, I've been working with the Nebraska Medical Association on an amendment to this section, which I have handed out to the committee. They've just asked that we make it clear that 48-hour time frame does not apply to clinicians, but only to therapy providers. Finally, subsection 6, we are asking for an expedited review when the medical necessity warrants an immediate response. Again, ensuring timely responses for patients that urgently need care. This bill ensures that we are giving equal care to Medicaid patients across the board, regardless of which managed care organization they happen to use. The intention of this bill is to promote quality of care, decrease patient cost, and create a better outcome for patients. The bottom line is that there's just one thing, if there's one thing that we can do now to address the problems we are hearing from patients and providers, this bill is extremely necessary if we want to ensure consistent and equal coverage for Nebraskans. With that, I would be happy to answer any questions, but I also know that there are people behind me who can. Thank you.
Thank you, Senator Walls. Any questions? Seeing none, thank you very much. First proponent.
Thank you. Good afternoon. Senator Arch, members of the Health and Human Services Committee. My name is Brian Brunken, B-R-I-A-N, B-R-U-N-K-E-N. I'm the chairperson for the Practice Management Committee of the Nebraska chapter of the American Physical Therapy Association. I also own a small private practice in the Millard West area of Omaha. I'm here today in support of LB895. Thank you, Senator Walz. I represent the 1,300 members of our chapter that serve Medicaid beneficiaries, especially in rural and urban areas. I also have the honor of being a member of clinical advisory boards for all three managed care organizations within Heritage Health. We appreciate the opportunity to work with these MCOs, and many times we have reached compromises. Again, as Senator Walz said, we want uniformity across all three MCOs, though. Some of these agreements also are not in writing. Some of them are verbal. So once again, hopefully this bill would solidify things. Briefly, this is the process by which a patient completes PT. The patient sees their physician, receives a referral for PT. Usually that'll stay 2 to 3 times a week for 4 weeks, 8 to 12 visits. Then the patient is evaluated in the clinic or home setting, and sometimes via telehealth now with the pandemic. Following this evaluation, the PT sets his or her plan of care. Next, the MCOs require the pre-authorization submission of both client and therapist information that was gleaned from the evaluation. This is so the MCO may approve therapeutic interventions. They use proprietary algorithms to determine if the therapy is medically necessary. Often the initial authorization derived from the algorithm or other methodology within the MCO does not grant sufficient visits to achieve the patient's goals. This results in multiple submissions of the pre-authorization process. If it's not completed, you do not get paid. LB895 is not intended to increase costs for the MCOs or for Nebraska taxpayers. However, it is intended to reduce administrative burden associated with this pre-authorization process, to achieve transparency from the MCOs and their sources for their algorithms, to allow therapists to provide care for 12 visits without pre-authorization, and finally to reduce the amount of time, currently up to 14 days, as Senator Walz stated, that the MCOs are allowed to render a decision. This delay violates the fact that better therapy adherence is noted when the patient, as she said, schedules their follow-up visit right there on their first appointment. This results in less anxiety, better outcomes, and fewer overall visits. Furthermore, following surgery, research supports early access to therapy, which allows for increased function, better therapy adherence, and again, better outcomes. Delaying physical therapy potentially increases the likelihood of an opioid addiction, which we know is a big problem in our country. PT has a potential to decrease opioid addiction by 10%. Just a one-day supply of an opioid increases the chance of addiction by 6%. Early PT for low back pain has been shown to decrease medical costs downstream, MRI, shots, those kind of things, surgery, by over $2,700. We appreciate the need for pre-authorizations for such things as major surgery or maybe experimental medications. However, in our case, it causes a lot of downtime in the clinic, and we don't get to treat patients as much as we'd like. There was a study done that administrative costs account for 1/4 to 1/3 of healthcare spending in the United States. Of course, this far exceeds other countries. 12 visits were selected as the average number of visits, and this was derived from a company called Photo. They do outcome registry for PT. So they looked at over 7 million patient episodes as their basis. Forgive me for assuming, but I would assume that at least half the cases could be taken care of in this manner without pre-authorization. In other words, under 12 visits. Nebraska Medicaid already has visit limitations. Therefore, adding further authorizations only adds a significant burden, all at my expense or all other providers' expense. Today, treating the patient is the easy part, as we fight for authorization to see the patient, complete the treatment, and then fight on the back end to attain payment. This is not sustainable long-term, and Nebraskans are not receiving the timely care that they need. I strongly encourage your support for this bill, allowing 12 visits without pre-authorizations. This will allow, again, Nebraskans the necessary care without delay, without interruption, create uniformity across all MCOs, and will decrease the administrative burden placed on us at our cost. Thank you, and I'll entertain any questions.
Thank you. Are there questions? Senator Williams?
Thank you, Chairman Arch, and thank you, Mr. Brunken, for being here. You work with all three of the MCOs.
Yes.
Through your practice. Am I correct in stating that some of these, there's not consistency between the three MCOs?
Correct. I didn't want to kind of bore you with those details, but my plan of care might match the physician's plan of care. For instance, we talked about 3 times a week for 4 weeks, so it'll be 12 visits. My plan might be less than that, might be a little bit more than that. But when you go ahead and then complete this prior authorization process, which we've been told an experienced authorization professional can do it in 4 to 5 minutes. I am 51 years old, it takes me 20 minutes to do it. But you might get 8 visits, you might get 4 visits. Then you come back after just 4 visits, say if you had a total knee or a rotator cuff repair. I see you Monday, Wednesday, Friday, and on Monday we're doing it all over again. And that just gets exhausting. And there's studies have shown, they've shared their data with us, that they end up giving us 12 to 25 visits depending on the type of diagnosis anyway. So,
Okay.
and we've talked to, sorry for interrupting, we've talked to other, like there's a hospital system in Omaha that's actually hired at least 3 employees just to do authorizations only. I know there's some people behind me that can speak to that as well that are other private practitioners. Thank you.
There are, as I understand it, 4 different disciplines: chiropractic, physical therapy, occupational therapy, and speech language pathology that are covered with this. I would assume in some cases there are people needing more than one of these disciplines.
Correct.
And so if we follow this, then each one of those would get 12 visits, correctly? Pre-authorized?
The way I understand it, yes, that is it's in its current state.
Okay. Any additional questions? Seeing none,
Thank you
thank
very
you for
much.
your testimony.
Thank you.
Invite the next proponent. Good afternoon and welcome.
Good afternoon. Need my glasses. Thank you. Well, Senator Arch left, but thank the rest of you for the opportunity to testify today in support of LB895. My name is Candace Mullendore, CandiceMullendore. I'm an occupational therapist as well as a private practice owner of a pediatric outpatient clinic in Papillion, Nebraska that serves children and youth with disabilities for occupational, physical, and speech language therapy services. I'm here today representing the Nebraska Speech Language Hearing Association as well as my private practice. As Brian mentioned, since the inception of Heritage Health, the Medicaid managed care organizations chosen to provide quality health to Nebraskans have implemented a variety of prior authorization processes that have resulted in our clients not receiving their medically necessary therapy services in a timely manner. As a provider, as well as a therapist, I have experienced the many iterations of Medicaid managed care organizations and their various authorization processes in the past 5 years. The intent behind LB895 is to simplify the authorization process and to ensure that providers can provide Medicaid recipients quality care in a timely manner. In the past 5 years, the administrative demand for meeting each MCO's requirements for authorization has become unsustainable. Medicaid recipients are 25% of my practice's patients. My practice had to hire an additional 1.5 full-time equivalents of administrative personnel to handle only the Medicaid MCOs. That cost is over $65,000 annually for my practice. This is a cost that some clinics may not be able to absorb and choose to no longer serve those recipients. This could decrease in access and care across our state. Speech therapists often see patients for swallowing disorders. When a speech therapist evaluates a patient with a swallowing disorder, it's often a deficit they need immediate therapy to prevent further complications such as aspiration. If you aspirate food that you're eating, it can result in a medical complication, which sometimes requires hospitalization. If a patient cannot access therapy due to a delay in receiving an authorization, we are putting that patient at significant risk for an unnecessary medical complication. I am here to tell you a story of a pediatric patient that 2 speech language therapists treated. This pediatric patient, we'll call her Michelle, had a stroke, which is a really rare occurrence in a child. The stroke affected Michelle's ability to safely swallow foods and liquids. She was at risk for aspiration and was placed on a modified diet, which means the speech therapist was working on the patient's ability to swallow a certain type of food safely. During her stay at an inpatient rehabilitation facility, Michelle and her parents, working with their speech language pathologists, have been able to provide Michelle with enough nutrition by mouth to prevent the placement of a gastric tube. which provides nutritional support for patients with swallowing challenges. Upon discharge from the inpatient rehab facility, Michelle was going to receive continued speech therapy at an outpatient practice. The outpatient practice submitted for an authorization, and due to a long response time, the new authorization was not in place prior to Michelle's discharge home. This left Michelle and her parents in a precarious position. Michelle was going to go out without speech therapy due to a 16 business day gap between her inpatient and outpatient therapy, which was almost 3 weeks in regular days. During this gap in care, Michelle lost many of her swallowing skills that she progressed to in her inpatient therapy. She was losing weight and was at risk for a placement of a nasogastric tube. The negative impact of waiting for an authorization on Michelle and her family was unnecessary, disheartening, and frankly put Michelle in a position to possibly have a medical complication, which would result in a higher cost for the MCO. The physical and emotional stress that Michelle and her family endured during this gap in care was immeasurable. Imagine if you were Michelle's parents watching her struggle to eat. Sorry, this gets emotional because I can picture this. And losing the skills that you worked so hard to improve while you're in inpatient rehab. Imagine worrying every day that you put your daughter on the scale, she was losing pounds. Imagine worrying that she could aspirate and become very ill. Imagine that stress as a parent. Now, imagine with the implementation of LB895 that stress won't happen for any of these parents. Imagine a seamless transition from inpatient to outpatient rehab and the incredible gains that a patient like Michelle could make. Imagine how you senators can make a difference for all these families through LB895. Fortunately, through intensive outpatient therapy after receiving the authorization, Michelle was able to regain her swallow skills. Michelle is only one story, and I wonder how many other patients like Michelle are out there that did not receive timely therapy that resulted in a negative outcome. Imagine the collective impact we can have on Nebraskans when this situation occurs many times a day across our state. A delay in therapy services is incongruent with published evidence and best practice, which compromises overall patient outcomes. With a decline in outcomes due to the delay in service, the Medicaid recipient may access the medical system more, which could increase the overall cost of healthcare. The implementation of 895 would provide parameters for authorizations to the Medicaid managed care organizations to approve therapy quickly and will work in the best interest of Nebraskans. Thank you, and I'll take
Thank you. Are there questions? I have a question. In your practice, you deal with Medicare patients, those that have private insurance, and those that you're dealing with the MCO with Medicaid.
Yeah, I don't accept Medicare because I'm pediatrics, but I have commercial insurance,
What
government.
is the pre-authorization requirements generally with the private insurance?
Generally, there is no pre-authorization for most private insurers. When the patient signs up for their health care, they're given a certain number of visits a year. So, for example, 60. And so they would know that they have 60 visits. You have to prove possibly medical necessity if they come for a retrospective review. But in general, the patient is allotted a certain number of visits for the year, and then you work with the family to figure out how they want to use those visits.
Any additional questions? Seeing none, thank you for your testimony.
Thank you, Senators.
Invite the next proponent. Good afternoon and welcome.
Good afternoon, Senator Williams, and members of the Health and Human Services Committee. For the record, my name is Dr. Nick Payne, N-I-C-K-P-A-Y-N-E, Executive Director of the Nebraska Chiropractic Physicians Association, testifying in support of LB895. Medicaid beneficiaries across the state of Nebraska have access to conservative care provided by doctors of chiropractic, as well as our colleagues in physical therapy, occupational therapy, and speech therapy. Pre-authorization is a widely used procedure in the Nebraska Medicaid system, yet it often leads to delays in medically necessary care, as well as increases in administrative burdens. Doctors of chiropractic have a unique process when we are interacting with the pre-authorization system in Medicaid. While some of the therapy services that we provide to our patients require pre-authorization, the main mode of treatment we have, the chiropractic adjustment, is not included inside of that process. Our association members are reporting that the prior auth system requires long waits on the telephone to obtain prior authorization or multiple phone calls back to the MCO to follow up on online submissions, which are supposed to speed up the process. It doesn't seem to work as well as intended. Oftentimes, care is denied or a very limited number are approved. This could be 2 to 3 visits potentially. This care is not adequate to take care of the patient's condition or really even get to the point where we have appreciable improvement. Then you have to start that pre-authorization process all over again. And it is definitely an inefficient and costly process. The current pre-authorization process has created a system that allows Medicaid beneficiaries to receive a small percentage of the care that may be recommended by their healthcare practitioner. A portion of LB895 requires the beneficiaries be allowed 12 initial therapy visits prior to authorization. This time frame allows for some consistency in treatment and some progress towards measurable clinical goals. The chairman of the AMA Board of Trustees, Dr. Kamala, has stated, "We're seeing people suffer more while we're waiting days or weeks to do what we know needs to be done. It affects our morale and how we practice, and it frustrates our patients." I believe the statement by Dr. Kamala represents our current situation with the pre-authorization process. In Nebraska, we currently have an environment that allows roadblocks to be placed between the Medicaid beneficiary and conservative care. This is in stark contrast to what the research tells us. We know from the research that's out there that conservative care as the initial mode of treatment results in better outcomes for patients and lower overall healthcare cost. In reality, the prior authorization process will likely increase the cost of the Medicaid program whenever a patient is forced to leave a conservative care environment and seek treatment from more invasive and more costly procedures. The NCPA is supportive of LB895 beyond the impact to our doctors of chiropractic. Our conservative care colleagues are facing even greater challenges that are negatively impacting patient care. Collaborating on this bill clearly has shown us the adverse impact of the current prior authorization system and its flawed and cumbersome delivery of care. Change is necessary to ensure that medically necessary, high-quality, cost-effective care is delivered. I want to thank Senator Walz for introducing this bill, and the NCPA asks the members of this committee to advance LB895 to general file for further consideration. I'd be happy to entertain any questions.
Thank you, Dr. Payne. Are there questions? I'm going to ask you the same question I asked the last testifier about comparing Medicare and private insurance to what you see with the MCOs and Medicaid.
So for Medicare, there is no pre-authorization for any chiropractic services. The majority, there's only a select few commercial payers that have any level of pre-authorization, and that's a very, very small percentage here in Nebraska. And then, of course, Medicaid, like I said, we are a little unique, so the adjustment that we provide is not what we are pre-authorizing, but it would be any other service, any other therapy service that we provide, such as electrical stimulation, therapeutic exercise, neuromuscular reeducation, things that we're doing to help assist that patient and progress them through treatment quicker to get that better end result in a more timely fashion.
Thank you. Additional questions? Seeing none, thank you for your
Thank you.
testimony. Invite the next proponent. Welcome, and thank you for being here.
Thank you, Senators, for taking the time to hear us today. I'm here to support LB 895. I'm currently a partner with Central Nebraska Rehabilitation Services. My name is Mary Walsh Stirrup, WALSH-STERUP. I'm an occupational therapist, and I'm going to speak on supporting LB 895 for the Nebraska Occupational Therapy Association, as well as a private practitioner. I currently practice, we have 14 outpatient clinics in Lincoln, Kearney, Grand Island, as well as several rural communities. Medical necessary therapy should be a consideration and collaboration between the physician and the patient, and is carefully thought out as the physician prescribes that therapy. As a provider of therapy services, I've witnessed delays and interruption in care on a regular basis over the past 5 years due to the authorization processes implemented by the current MCOs. We have worked with all 4 of the MCOs. There's 3, WellCare used to be here, and worked with them and addressed their authorization processes. It's those processes that have brought me to this committee prior to speak on the difficulties that we have had. The significant amount of administrative burden that is pushed onto the provider makes it long-term unsustainable. But more importantly, what it's doing to the patient. And my colleagues here have really talked about the administrative burden and how it's affected all of us. So what I'd really like to emphasize today is to give you some real-life stories about how this has affected patients. We are a fairly large provider. We provide PT, OT, and speech services. And so literally, when I asked my team for examples, I probably had 100 examples that I could have easily shared with you. First is a patient that had a shoulder surgery. She was referred to therapy. The doctor ordered 3 times a week for 12 weeks. We submitted authorization and we received 8. We had to submit for an additional authorization. 3 weeks later, we received 3 visits. Then submitted for an additional authorization 2 weeks later and received 6 additional visits. We had 17 total visits provided. We did seek an additional authorization and it was denied. They wanted the patient to wait a period of time before resuming any additional therapy. So we ended up having 17 total visits provided. Each one of those authorizations took our clinicians about 20 minutes to complete. The patient returned to the physician 1 month later and had significant increases in shoulder tightness, advanced adhesive capsulitis, and was referred for additional services. And so we had to start the whole process all over again. Another patient had a shoulder injury. We completed the evaluation at that time, started early active range of motion. The patient was submitted for authorization. 14 days later, we received the authorization. The patient attended their second appointment for therapy 16 days after their initial evaluation. This was a significant delay in the patient's care. The patient presented with significant tightness and limited range of motion. A perfect example of delay in medically prescribed therapy resulting in increased complications for the patient. CT was a patient that was referred for neck pain and severe headaches. An evaluation was completed and we had to put the patient on hold until we received the authorization. During the period of hold time, the patient contacted our office and asked about therapy. We had to continue to tell her that she was on hold. Authorization was received 12 days later. Further attempts to call the patient found that the patient's phone was no longer in working order. We then attempted to try to contact their emergency contact to see if we can locate the patient to get them scheduled for their treatments. We were unable to locate the patient, and we had to send back to the physician a letter indicating that we were unable to provide the prescribed medically treatment due to delays in care with the authorization process. DK is a student athlete who sustained an ACL strain, and his home was in northern part of Nebraska, and it was almost 60 miles that he came into our clinic. We had to complete the evaluation, and we felt like because of the instability in his knee and knowing that he was going to be going back to performing sports, that we wanted to get him started on treatments right away. We called for an immediate authorization, and we were told by the authorization clerk that nope, 14 days was what they were allowed and don't expect to get anything for 14 days. So we had to deal with, do we do the right thing by the patient and go ahead and treat the patient knowing that we're not supposed to by the MCO, or do the right thing by the MCO and not treat the patient. Here was a kid who was an athlete, was going to return to sports, and could have sustained a significant injury to his knee. Our therapist was very concerned about him, and we did go ahead and treat this patient anyway. These are just a few examples of real-life stories of how the authorization process has limited our ability to treat our patients effectively and in a good manner of time. So, thank you.
Thank you for your testimony. 5 minutes goes faster when Senator Arch isn't here. So we speed that up. Jerry does that over there. Are the examples that you're citing here all examples that we're dealing with MCOs?
Correct. Yes.
I wanted to be sure that I understood that. Are there questions?
Questions?
Seeing none, thank you for your testimony. Invite the next proponent. Welcome, Mr. McDonald.
Hello, my name is Edison McDonald, EDISON, MCDO, and ALD. I'm the Executive Director for the ARC of Nebraska. We advocate for people with intellectual and developmental disabilities. We're here in support today of LB895 because many of our members have struggled with the lack of clarity and the bounce back and forth from providers to MCOs. This has created a number of expensive issues and delays or denial of care, as we've heard in previous stories. This prevents individuals from getting the care that MCOs are supposed to be providing. This is an issue that we regularly deal with, and we've seen some key spikes in denials or delays. Typically, for some families we've worked with, this requires a bounce back and forth between doctors, chiropractors, physical therapists, occupational therapists, speech therapists, and managed care organizations that are confusing and frustrating. This requires a huge increase of time from families who have to spend an inordinate amount of time and effort on calls and filling out excessive paperwork. For some families, this ends up being days out of their week. This also makes it more difficult for those providers to maintain profit margins, so many begin to want to shift away from those clients. While this undoubtedly won't fix all of the issues with prior authorizations, we believe that this bill is a significant step in the right direction. We hope once this passes to track this issue further and better determine what other changes are necessary. And I just wanted to share, I've really seen this issue over the last few years, and it always seems to come and go in waves. We have one kind of change within a certain MCO's process in terms of how they deal with these issues, and then all of a sudden I get all sorts of calls in from families who are dealing with this. But there's one in particular where we had a huge spike, and I had a number of families who met with me and talked with me about this issue. And I heard these stories about these individuals who they wanted to go to therapy, but for our individuals, making sure they have consistency in their life, consistency in how they get their therapy, consistency in their week, in their schedule is very important to address their disability and their needs. And so really ensuring that we have that consistency and that we eliminate the yo-yo process back and forth is so important, because ultimately for so many of these families, if they go and have the prior authorization for a couple of sessions and then they don't know if they're going to, it really just kind of leaves them stuck between a rock and a hard place. And a lot of times it's almost more logical to just say, let's not go ahead and do this for some of those families. And with that, any questions?
Are there questions? Seeing none, thank you for your testimony. Invite the next proponent. Good afternoon and welcome.
Good afternoon, Senators. My name is Amber Woods, AMBERWOODS. I am the Revenue Manager for CenterPoint, and we are a behavioral health organization operating in Lincoln and Omaha. I'm here today representing CenterPoint and the Nebraska Association of Behavioral Health Organizations, who also represents numerous behavioral health providers, hospitals, regional behavioral health authorities, and consumers throughout the state. I thank you for the opportunity to testify in support of LB895 and to speak toward including behavioral health in this bill. Like many of the chiropractic, physical therapy, occupational therapy, and speech pathology services in Nebraska, behavioral health providers shoulder vast administrative burden that accompanies contracting with Medicaid providers. You've just heard several proponents speak about the issues that they're having, and behavioral health providers and organizations experience the same issues with the lack of transparency, incongruous processes, and erratic communication when requesting authorizations for services. At CenterPoint, we utilize evidence-based practices in each offered program to treat individuals with behavioral health disorders. However, when requesting authorizations for these services for managed care payers, we are often denied and deferred. The reasons for denial vary. We have received authorization and denials stating individuals no longer meet medical necessity because they showed a modicum of progress. Our supplied clinical data is suddenly insufficient. Managed care physicians' subjective understanding of what meets the clinical criteria is used to determine service eligibility. Authorization deferments can persist for months and are typically caused by errors of the payer. When following up on authorization requests, we are told that the initial paperwork was not received, despite us having fax confirmations to the contrary. We're given authorizations that are issued to the wrong services, or we're given partial approval, which grants authorizations for only 3 to 7 days for long-term care programs. These tactics exemplify the need for consistency in service authorizations. One of the most significant issues we experience in authorization denial for our long-term treatment programs is the denial for the individual's second month. In our co-occurring residential treatment facility, that happens about 35% of the time. The average length of stay for similar programs throughout the state is 6 to 9 months, yet we fight for initial OSS and appeal denials for OSS 1 month, and we do this on a daily basis. Our community support program suffers with this issue as well. Although this program is economical in cost, it offers our individuals the most stability over time, and it prevents the need for higher levels of care. Yet in the last 12 months, we've lost over $36,000 to inexplicable authorization denials for this service. As a nonprofit organization, there is considerable financial burden on billing staff who spend months chasing payments for clean claims. One managed care organization that we contract with has held on to payment for authorized services for 461 days, despite numerous attempts on my part to resolve the issue. To date, we are owed $265,000 for services that were denied for no authorization when in fact an auth was in place. So oversight to ensure claims are paid correctly and within 15 business days from receipt eases not only the burden on contracted agencies, but on our individuals in service who often receive convoluted letters about these incorrect denials. Our client population is vulnerable, and the undue stress of believing they now owe medical bills topping out in the thousands causes them unnecessary harm. Managed care organizations need to be held accountable for and transparent with their authorization processes. The provision that managed care organizations expedite review of the authorization requests and use evidence-based clinical guidelines consistent with professional standards would ensure frivolous authorization denials are a thing of the past. It would reduce administrative time spent drafting appeals and scheduling state fair hearings that are suddenly canceled when the managed care organizations reevaluate the submitted clinical data. And the provisions outlined in LB895 would allow specialized providers to focus on delivering quality care rather than the impending battle for authorization and payment from managed care organizations. By including behavioral health in LB895, you will enable behavioral health providers the same assurances and financial protections resulting from these standardized and consistent authorization processes. I thank you for your time and welcome any questions you may have.
Thank you, Ms. Woods. Are there questions? Senator Merman.
Thank you for testifying. I guess I didn't follow your figures on, the monetary figures on your losses. Were those for providing care that wasn't authorized and so you didn't get reimbursed?
Yes.
Thank you.
Yes. And for care that we had attempted multiple times to get authorization for.
Thank you.
Additional questions? Seeing none, thank you for your testimony. Invite the next proponent. Now, welcome, Mr. Schroed.
Vice Chair Williams, members of the Health and Human Services Committee. My name is Dexter Schrodt, DEXTERSCHRODT. I'm Vice President of Advocacy for the Nebraska Medical Association, here to testify in support of LB895. As you all know, I'm not a healthcare provider, so I can't add much more than what you've heard. I will say in my time at the NMA, I've heard complaints about every single one of these issues. So I will say it was nice to see this bill and see what this bill is attempting to do. And especially, Senator Williams, you mentioned the 12 visits, and while it is reserved for the therapy services in there, as you heard from Ms. Walsh-Sturrup, every time that comes back to the physician office. So then that creates more work then for our physicians in their offices having to then send it back to the MCO to get it back onto therapy. So it does help us in that regard. And most of all, I would like to thank Senator Walls and her LA Amanda for working with us on the amendment that you had passed around. That amendment, I'll just explain briefly. Our physician members reviewed that. The 48-hour window gave them a little heartburn because if it's not turned around in those 48 hours, for physicians anyway, it then results in automatic denial, which then creates more work for the physician office and the MCO. So an extra 24 hours on there would meet the time frame that our offices would like to see, not be too crunched there, but still have a requirement in place while still allowing therapy services to have the time frame that meets their needs. And with that, I ask for the committee's support.
Are there any questions? Seeing none, thank you for your testimony. Invite the next proponent. Is there anyone else here to speak in support? If not, we'll move to opponents. Invite any opponents. Good afternoon and welcome.
Good afternoon, Senator. My name is James Watson. It's James Watson, and I'm the Executive Director of the Nebraska Association of Medicaid Health Plans. Those plans include Nebraska Total Care, United Healthcare Community Plan, and Healthy Blue Nebraska. I thank you for the opportunity to testify before you. I'm here to respectfully express the Association's opposition to the introduced version of Legislative Bill 895. We oppose the introduced version of LB895 in large part because the Medicaid and Long-Term Care Agency has announced that it will be procuring new contracts in 2022. The current version actually was done in 2015. The first version was done in 1996. So this is sort of it's a routine happening that an agency will reissue RFPs to gain improvements. From listening to the testimony and also from conversations with our membership, it seems very clear that what is needed is data to find out really what's going on. MLTC has every data set from every MCO across the board. And what we would expect is when the issue is looked at by MLTC, they would look at their data, drill down, figure out what is exactly happening, and address those issues in the prior authorization process. But if you do it by contract as opposed to statute, it allows for a lot more detail and flexibility by MLTC. And even as they go along during the term of the contract, they can amend it, and the MCOs will look at it and almost always comply. So they have the flexibility to provide oversight on a consistent basis and use data when they do so. The current contracts, as I said, were led in 2015, and they do provide a comprehensive regulatory framework for managed care organizations to provide services. In fact, they're over 2,000 pages long. With new agreements in mind, though, MLTC conducted listening sessions throughout January 2022. There were 5 locations across Nebraska. 2 virtual sessions were also held. And we know from looking at the results that the LB895 proponents took advantage of the opportunity, as did the Nebraska Association of Medicaid Health Plans. The second concern that we have is that LB895 would require disclosure of algorithms which are proprietary. I want to state that the health plans don't have opposition to providing guidelines. That is different than an algorithm. An algorithm is like a checklist which is used as a decision aid in many industries to safeguard against mistakes, safely guide a path forward. In healthcare, health professionals are now using these same strategies, using proprietary algorithms with artificial intelligence systems to guide the development of approval criteria. MCOs are in fact required to be transparent with the criteria that is used in evaluating requests for authorization as required by Nebraska law and the contracts with MLTC. Adding the disclosure of proprietary algorithms should not be necessary. Relatedly, in developing its principles on artificial intelligence applicable to insurance companies, the National Association of Insurance Commissioners discarded the concept of requiring insurers to disclose their algorithms to state insurance regulators. They stated that for the purpose of improving the public's confidence in intelligence, the actor should submit to transparency and make responsible disclosures of what's underneath. The proactive disclosures include revealing any kind of data being used, the purpose of the data, and the artificial intelligence system and consequences for all stakeholders. We also believe that the prior authorization exemption for 12 visits is indeed excessive. It's conceivable that a minimal number of visits without prior authorization would be desirable with certain but not all therapists and chiropractors. Insurers programs that grant prior authorization exemptions work by very carefully selecting the providers eligible for these programs. Generally, the provider has to be under contract with an insurer for a certain amount of time, meeting established quality goals. With regard to specialty review and reviewer turnaround time, the criteria for an initial approval is developed by MCOs based upon updated clinical information, which provides sufficient guidance to reviewers. NAMHP does not believe it's necessary for a same specialty review initially, although specialty input can be furnished in an appeal as required by NCQA. Mr. Chairman, with your permission, I just have a couple more comments. If I could.
Please, but summarize if you would.
Yes, I will. Lastly, NAMHP believes that any turnaround time for reviews should be guided by the member's medical needs. The clock should not begin to run until all needed information is submitted, rather than automatically when the request for prior authorization is made, as listed in LB895. We would urge that the NCQA standard of 72 hours, in fact, be followed, and all the MCOs are NCQA accredited by requirement of MLTC. And with that, I conclude my testimony, and if you have any questions, I'm happy to entertain them.
Thank you. Are there questions from the committee? Senator Kavanaugh?
Thank you. Thank you for being here.
You're welcome.
So the algorithms are proprietary, and I was reviewing the language on that. I'm not going to speak for Senator Walz, but the way that I read it, it seems like the intention is to create some transparency in the decision-making process for how you're deciding or to approve or not approve these. So is there some middle ground there on how to create more transparency in the decision-making process?
The MCOs are available and willing to provide the clinical guidelines, which actually drive the decision-making. We are just objecting to the idea of algorithms, which we use to analyze the data to provide the pathway, and are purely internal, because we don't think they're necessary. But the guidelines, absolutely, is required by the NCQA as far as I'm concerned.
So what I was hearing from earlier testimony, and I believe even from Senator Walz's opening, is that sometimes these requests are being denied and there's no explanation. And so if we had transparency in what the basis of the decision-making was, I think that might have been solving for it. But again, I'm not trying to speak for Senator Walz here. I'm just asking my questions. But is there, why are you explaining, why are the MCOs not explaining why they are denying the claims?
There should be a rationale given at the time of denial by someone with sufficient clinical expertise to do it. I don't know the facts of the particular situation that they're talking about. I do know that each of the three MCOs has met with the proponents in various capacities, whether it's by an association or by visiting a practice. All three of them have tried to put their hands around this for their companies. There isn't anywhere where the data across all three MCOs exists other than with MLTC. because we're prohibited by antitrust considerations for sharing data between us. And it just doesn't happen. But MLTC has the data, and we file it with them, and I think if they study it, they will find some things that they can do. I can't guarantee that, but as far as I know, it's not been done that way with data.
Okay, I have additional questions, Doug.
Yes,
Okay.
please.
So to the 72 hours, you said that that's, the standard of 72 hours should be followed.
Should be. I mean, it's an NCQA standard for
Okay.
a standard inquiry.
So I guess if it should be followed, then why is there an issue with putting that into, as a requirement?
Into the bill?
Yeah.
Oh, I don't know. Senator, my comments are directed at the green copy of the bill. That's what we had available.
Okay.
If there's efforts to rewrite things or something like that,
Okay,
we're
so
not
I'm
aware.
sorry. So you were referring to the 48 hours, sorry.
I was, yes.
Okay, I apologize, I didn't catch that part there. Okay, so, but you're not opposed to 72 hours being amended
For a standard request.
for a standard request?
I still don't like the idea of it being in a legislative bill, because that's really, I think it's MLTC's program, and they're studying it, and we ought to let them do that. It can only result in an improved program.
From a legislative side of things, we're just trying to put guardrails in our procurement
course,
process
I
as much as
understand.
we can.
I understand.
So, thank you.
Yes.
Other questions? Senator Williams?
Thank you, Chairman Arch, and thank you, Mr. Watson. A couple of times in your testimony, you used the term you're opposed to the introduced version.
That's correct.
Of the bill, and talking about the fact that the RFP is coming out
Yes.
this spring and getting to that. And this committee has been very involved with wondering about this procurement process and that issue. In fact, that's where Senator Arch has been testifying this afternoon outside of here. Would you be opposed from the MCO's standpoint if the RFP included the language primarily of Senator Wall's bill? Do you think that's something that you would be, generally, the MCOs would be opposed to?
If the RFP contained it, it would mean that the MLTC people had made a decision to do it that way. And that does make some sense in terms of it is their money. It's the state taxpayers' money. However they decide to do it, when they put language in an RFP, it becomes public. Carriers bid on it, and it's usually a very extensive document. But as I say, if that's what MLTC decides, then people bidding are going to have to deal with it and live with it.
I understand your concern about the proprietary nature of the algorithms. For those of us that have sat in these seats since Heritage Health was rolled out, one of the things that we consistently battle on the part of providers and their clients are the differences or inconsistencies between coverages in that.
Right.
Is it fair to assume that even though you cannot and would not disclose the algorithms, that the algorithms for each of the three MCOs would arrive at the same result for a provider requesting?
I couldn't say that because I'm not sure how internally the MCOs are using algorithms. I mean, they are internal tools.
And you see how that answer gives us pain.
Of course.
Because we're asking our constituents, these providers, to deal with three MCOs, and this one does it this way, this one, and that.
I think there's a great opportunity.
We would all like to see more consistency. Thank you.
You're welcome.
Other questions? See none, thank you very much
Thank
for your
you.
testimony.
Appreciate it.
Next opponent for LB895. Is there anyone that would like to testify in a neutral capacity for LB895? Seeing none, Senator Walls, you're welcome to close. As you're coming up, I would let everyone know that we received 7 proponents' letters For LB 895, no opponents and no neutral letters.
Thank you, Chairman Archer. I just wanted to emphasize again just how important this is. We are trying to make sure that patients receive equal, consistent, and timely coverage for much-needed treatments. And again, LB 895 intention is not, just looking at specific managed care organizations and picking on them. That's not the intent. We just want to make sure that when DHHS does their next RFP process, that it's a smooth transition for patients and providers. I think that a couple days ago, we saw a quote from the Health Center Association of Nebraska, and they submitted a comment that said, gaining approval often takes multiple follow-up phone calls and additional requested documentation, and seems to lack consistency from patient to patient and between managed care organizations. So most importantly, these delays and inconsistencies result in delayed treatments for patients, which can exasperate medical conditions. I wanted to, and now I can't read my notes, Amber Woods, who came to testify here for CenterPoint, made a really good point about the behavioral aspect of this. And I think that it is something that we also need to be looking at, because we all know that behavioral health is vital to, the people, our constituents. And I think it's also something that we need to be discussing in the future when we have these conversations. I know that providers and MCOs have met. They've met several times to come to an agreement on how we can assure consistent and timely care and coverage for our constituents and patients. And I was hoping that a proposal would be brought and agreed upon prior to today's hearing. And I'm still hoping, actually, that something can happen in the near future, and that it also, that we have conversations regarding behavioral health. It's always better when we can find solutions together. I mean, just let's work together, let's find a solution, because that just makes it much more quicker to provide quality care to the people that we serve. So thank you for taking the time to listen, and to all those who came to testify today, I'd be happy to answer any other questions.
Thank you. Any other questions? Seeing none, thank you for trying to come to agreement on
You're
some
welcome.
of these things. With that, we will close LB 895.